All right, yep, we're all good. All right, so we'll go ahead
Okay,
and get
great. So, so thanks everyone for coming. Today, Dr. Claudio Verlado is going to be talking about sleep disorders in spinal cord injury. With that, Claudio, please take it away.
All right, thank you, Dr. Abramoff. So welcome in, everyone. Welcome to the April SCI in-service. Today, we're going to be talking about a hot and growing topic within spinal cord injury, which is sleep disorders. I think all of us as rehab professionals are looking for ways to move the margin for our patients in terms of improving their quality of life and outcomes. And as you'll see by the end of this presentation, sleep is a big role in trying to do so. So, getting started here. For my disclosures, unfortunately, I do not have any lucrative deals sponsoring this talk today. These are going to be our objectives for the talk. I'll give you a second to look through them. But a more engaging way, I believe, for covering the content is going to be through questions. I was able to split this presentation into two parts. The first part looking at the foundation of this relationship between sleep and spinal cord injury. We'll answer questions like how common are these disorders in patients with spinal cord injury. We'll also talk extensively about sleep disordered breathing. We'll define it, talk about the pathophysiology and some of the risk. We'll move on to talk about what's the functional impact of sleep disorders, and then briefly discuss treatment and interventions. Second part of this presentation today will look toward the future and what future approaches can better address sleep disorders and spinal cord injury. And I really wanted to kick this presentation off with a slide that should be familiar to many of us on the call here today. These are the specific domains that we cover during our weekly team interdisciplinary meetings. And as you'll notice, and as you're familiar, one of the things we talk about is sleep barriers. I want to propose another question, which is, should we be doing this? Should there be a targeted focus on the management of sleep in individuals with spinal cord injury? So diving into our story, starting with the foundation, looking at this relationship between spinal cord injury and sleep. I think a great question to begin this conversation is, why do we sleep? Why do we sleep in the first place? Does it matter? Whether you like it or not, we all have some type of relationship with sleep. And paradoxically, we sleep about 1/3 of our lives, yet it doesn't feel like we're achieving anything useful during that time. I love this quote from a sleep researcher. If sleep does not serve an absolutely vital function, then it's the biggest mistake the evolutionary process ever made. When you think about it, we're not doing anything to promote our species. We're not foraging for food. We're extremely vulnerable for when we sleep. So why did this process continue to get passed on through all animals across the world? As we've come to learn, sleep has a major role in our wellness and longevity. It factors into mood regulation, cognitive function, memory formation. Additionally, immune and hormonal regulation has large roles with. And then we see this association with chronic disease prevention, ties with dementia, cardiovascular disease, and metabolic diseases, to name a few. If you're interested in this topic, Why We Sleep is a great book. That's mainly the reason I'm actually giving this talk today, is this book inspired me to be more interested in sleep and its impact on our overall health. So taking this a step further, if you look anywhere in the news, there is a lot of talk about sleep more recently over the past few years, even so much so that the AMA declared sleep deprivation as a public health crisis this past year. So something that even large health organizations are paying more attention to more recently. So looking more toward spinal cord injury, how common are these sleep disorders in spinal cord injury? Well, as it turns out, they're highly prevalent. And when we go right to the patients and ask them, what health conditions are impacting you? What health conditions are bothering you most? A recent survey, over 1,500 community-dwelling individuals with spinal cord injury, sleep was among the top 5 problems that they listed, with 78% reporting that it was an issue for them. And then we look at, when we ask them as a follow-up question, is it being treated? It was actually the second most likely to be untreated, right behind sexual dysfunction. So it's impacting our patients, and it's also often something that we're missing and not really perhaps addressing for them as early on as we should be. When we talk about the different subtypes, though, we see that sleep disordering breathing by far by far and away is the most predominant sleep disorder, with obstructive component being more common than central or mixed. We'll talk more about this in detail in a little bit here and what that means, the sleep disorder breathing. And just hold on one second here. I'm just going to pause for a second. Bear with me. All right, apologies for that delay. I had to deal with a call. All right, so picking up where we left off, talking about sleep disorder breathing, what it means. Let's look at some of the numbers here, though. So when we're looking at the numbers of how common sleep disorder breathing is, a recent meta-analysis over 9 studies in spinal cord injury patients with tetraplegia, 83% had mild sleep apnea, at least mild sleep apnea, meaning some had moderate, about 50%, and some had severe, about 30%. These are pretty drastic numbers when we're thinking about our population. That means that if you were to look at somebody with spinal cord injury, true spinal cord injury, it's more likely than not that they have some form of sleep disorder breathing than they don't. And in fact, this risk is 3 to 4 times greater in spinal cord injury patients compared to the general population. All right, taking a step further, looking disorder by disorder. Again, sleep disorder breathing is going to be our most common subtype. Pretty profound numbers when you're looking at the prevalence in spinal cord injury. That's the most researched category out of all these subtypes. So a lot more data to support that it is pretty prevalent. And then different subtypes of sleep disorder breathing include obstructive sleep apnea, again, pretty high rates, more than central or hypoventilation related. A lot of SCI patients identify insomnia symptoms, although they don't necessarily carry the diagnosis of true insomnia disorder. This may be secondary to a gap in identification of these patients and truly label them within our health system. And then again, restless leg syndrome, also fairly common. That I put that little asterisk there to note that 100% was from a smaller study, so it may be less reliable, but either way, we see that much higher than the general population across the board here. Sleep disorder breathing, as I mentioned, a 3 to 4-fold increase. All the subtypes are much higher. Additionally, restless leg syndrome we know is higher, however, to the degree it's not clear. Insomnia, about the same rate, despite the symptoms being more prevalent. And we'll talk about the impact insomnia has a little bit later. So why do we use this term sleep disorder breathing? Should we be using it? It's particularly useful for these types of patients because they often experience multiple types of breathing abnormalities at the same time. It also acknowledges that there's a difference in treatment. While we know that CPAP is very effective for obstructive events and obstructive sleep apnea, that's not really the case for central or hypoventilation type syndromes, where we may look at using BiPAP or these adaptive servo ventilation devices, which adjust the pressure throughout the night. And just to take this one step further, it is really an umbrella term. So it's covering all these different types of apneas and hypoventilation, obstructive being more related to airway collapse, central sleep apnea being more secondary to an absent respiratory effort from the brain and brain stem, mixed meaning a combination of both, and hypoventilation meaning there's no true apneic events. However, there are episodes where a patient is getting inadequate amount of ventilation in. So why does this occur? We've established that it's very common in our spinal cord injury patients, but what's driving it? We see a couple different factors coming into play here. Central respiratory control being impacted, There's differences in upper airway collapsibility in spinal cord injury patients, as well as respiratory muscle weakness. And then lastly, there's a change in autonomic outflow. As we'll come to learn, the autonomic nervous system has a role in controlling sleep and directing sleep. Starting with the respiration component, from an obstructive standpoint, we see that there's a lower threshold for pharyngeal collapsibility, and this is independent of injury level. So whether a patient's cervical or thoracic, we can still see that this level that they need to have pharyngeal collapsibility is decreased. From a central standpoint, we're looking more toward our PCO2. This is what the brain uses to help control our respiratory drive. In cervical spinal cord injuries specifically, we see that this window becomes narrowed, and they're more likely to have an apneic episode with this window. Then lastly, when we're talking about hypoventilation, due to respiratory muscles being weaker and having some desynchronization, we can see these episodes of nocturnal paradoxical breathing, which ultimately lead to hypoventilation. When we're looking at the autonomic system and its impact in spinal cord injury, we know that the autonomic system in general has a critical role in sleep regulation. There's big changes in sympathetic and parasympathetic balance throughout sleep stages. And there's this bidirectional relationship where if you impact your autonomic nervous system, you're more likely to have a sleep disorder, and the opposite is true. If you have a sleep disorder, you're more likely to have autonomic dysregulation. Looking at the graph on the side, this is just comparing mean heart rate, mean blood pressure, and actual sympathetic burst or frequency of sympathetic tone. You can see that it's much higher in the REM stages compared to other stages of sleep, indicating that there is a difference in the amount of sympathetic and parasympathetic activity throughout the night. In high thoracic or cervical spinal cord injury, we see that they may have altered hemodynamics and changes in their sympathetic outflow, which can impact our normal physiologic sleep patterns. And I want to include a key note about awareness here. In general, us humans, we have pretty poor subjective sense of our sleep deprivation. Throughout multiple studies, humans tend to consistently underestimate the degree of their performance impairments. As you can imagine, for the spinal cord injury, this isn't much different. These patients are very often underdiagnosed because they tend to lack majority of these subjective symptoms. A unique part that's more specific to spinal cord is they lack daytime sleepiness in these apnea type pictures. So we see that standard screening questionnaires, such as the Epworth Sleepiness Score, is pretty ineffective in spinal cord. And given the high prevalence of asymptomatic obstructive sleep apnea, there's some authors and researchers now recommending baseline formal sleep studies and objective scoring measures for our patients. I thought this was so important that I decided to put a big red star here so you don't forget it. The absence of daytime sleepiness is the key factor that prevents our spinal cord injury patients from being identified and seeking care. Despite this change of not having the daytime sleepiness, we still see that spinal cord injury patients experience neurocognitive and snoring typical of sleep apnea. And the mechanism for this phenomena is currently unknown. It's hypothesized to be related to the autonomic function that we discussed a little bit earlier, also maybe potentially changes in the sleep architecture following spinal cord injury. Either way, the take-home message is clear that we must have a low threshold for testing these sleep breathing disorders in spinal cord injury, given that we're often missing these patients because they don't present typically. All right, so what are some of the risk factors? We've identified that these disorders are common. We've kind of talked about how they happen and how these patients present. So risk in sleep disorder breathing, it includes tetraplegia, so our higher level injuries, more common. Also more common in complete spinal cord injury compared to incomplete. Other risk factors that are consistent are those amongst the general population as well, which is higher BMI, neck circumference, and older age increases your risk. When it comes to insomnia, we see the strongest associations with depression, anxiety, and PTSD. And pain can also be a contributor. We see that more neuropathic pain interferes more commonly with sleep than non-neuropathic pain. So what do you think? Now that we talked about some of the risk factors, Are complete and lower level injuries safe? Do they get to avoid all these sleep disorders? The answer, unfortunately, is no. So we also see that restless leg syndrome. It's more common in lumbosacral spinal cord injury compared to the cervical thoracic. It may indicate a possible predisposition. However, we need more studies to really confirm that. Additionally, periodic leg movements, which is a type of sleep disorder which often is associated with frequent awakenings, they're more common in incomplete motor lesions compared to complete. So all things to think about, even if our patient has a lower or incomplete injury, they're still at risk for sleep disorder and likely should be screened. Again, bringing up this question that we mentioned earlier in the presentation, should we focus on this? Does this really matter? Should we screen our patients for sleep disorders? At this point, you're just ready. Does it impact recovery? Does it impact function? Starting with sleep disordered breathing, from a clinical standpoint, certainly it does. We see that there's adverse cardiovascular outcomes in patients that have sleep disordered breathing. Includes things like nocturnal hypertension, increased stroke risk, and cerebral vascular response, which is just cognition long-term. Specifically for spinal cord injury, we also see that patients that are treated for this have reduced daytime sleepiness for those that experience it, marked reduction in symptoms of autonomic dysreflexia, as well as orthostatic hypotension. In terms of the functional outcomes in spinal cord injury, it's much more theoretical. So it may contribute to neuropathic pain, spasticity, and autonomic dysfunction, all of which obviously will impede rehabilitation. Additionally, similar to our brain injury patients, chronic inflammation with sleep disorders may impair neuroplasticity, impacting function. However, unfortunately, there is no clinical trials that have been completed looking at functional outcomes when we treat this in spinal cord injury patients. Yet, that's soon to change. There's currently an ongoing trial, which we'll talk about toward the end of this presentation, which is the optimized SCI trial. When we talk about insomnia and its impact on recovery, as we already mentioned, there's very strong associations with psychiatric comorbidities, anxiety, depression, PTSD, to name a few, and also can indicate worse daytime functioning, fatigue, quality of life, community integration as well, and some associations with employment after spinal cord injury as well. There's been a recent study, Batter's group from 2025. They looked at 38 veterans with spinal cord injury. They wanted to associate sleep parameters with functional outcomes. They saw that worse insomnia or more severe insomnia based on ISI scores correlated with worse spinal cord independent measures, which is just a measure of function after spinal cord injury. Additionally, worse sleep quality also is associated with worse fatigue. So both of these kind of really indicating that there may be some impact on function, and we should be addressing insomnia in our patients. All right, so now what about treatment? What can we do about it? So starting with sleep disordered breathing, CPAP is our preferred treatment for any of the patients that have an obstructive predominant sleep breathing disorder. However, unfortunately, CPAP tolerance is extremely poor in our SCI patients. There's obvious physical limitations here. Tetraplegic patients require assistance to don, remove, and adjust the devices. There's obvious mass discomfort and claustrophobia that can be associated. And then some of these patients also have a higher degree of air leaks and more errors with actually using the machine. BiPAP, as I mentioned earlier, can have a role here, especially those that have more predominant hypoventilation type patterns. And then there's also a role for adaptive servoventilation for a lot of these patients, as many of them have a mixed, a central component or a combined component that would really fit this category and benefit from it. And I also put this quote in here, while most people with spinal cord injury have sleep apnea, only 15 to 20% are treated for it. So there's a large gap that we're just not addressing in these patients. What about insomnia? How can we address this? Well, in the general population, we see that cognitive behavioral therapy is the recommended first-line treatment. Unfortunately, there's been no clinical trials looking at this in spinal cord injury. And then there has been some small studies trying to address insomnia, and we see that a lot of the comorbid symptoms, such as depression and anxiety, have improved afterwards with treatment. And as we talked about extensively, there's a lot of ways to improve quality of life by addressing insomnia, whether that's with cognitive behavioral therapy or pharmacologic approaches that we take. So turning the page, looking toward the future, what's the future directions of addressing sleep disorders in spinal cord injury? A couple places we're going to look at novel treatment approaches. We're going to look at some different screening protocols that can be integrated for the future. As we talked about, this is a big issue that's ongoing. And then ultimately trying to understand the impact. What's the impact on function via the optimized spinal cord injury trial? Starting with novel treatment approaches, the mandibular advancement devices have been a kind of hot topic recently in spinal cord injury. These are custom fit or prefabricated oral appliances. What they do is they move the jaw and tongue forward and increases airway space. They're ideal for our spinal cord injury because many of the patients, as we talked about, can't tolerate CPAP, and this device is much better tolerated. So there's a recent study from 2025 looking at these devices more specifically in spinal cord injury. And what they're looking at is the average number of events, so breathing pauses or shallow breaths per hour of sleep. They define it as this term called mean apnea hypopnea index. And they saw the number of events decrease at the 6-month mark after using this. So it went from 35.7 to 18.5. Additionally, almost 50% achieved a greater than 50% reduction in the number of these events. So we're making a difference by actually using it. And those that experience daytime sleepiness, we see an improvement in the score using ESSS. So less were experiencing daytime sleepiness after 6 months using this device. So potential option and something that may become more standard as we go into the future. All right, well, we talked about the issue with screening. So is there any new objective models that are being created? We talked about there's a high amount of these patients that are asymptomatic with obstructive sleep apnea and the failure of subjective screening models. One area that's picked up over the past 5 years is overnight oximetry. It's cheap, accessible, and accurate, and can be used in this population. Some have suggested using a 2-model system where we modify questionnaires to include more objective information or more information that's specific to spinal cord injury, and then using and integrating overnight nocturnal oximetry. They evaluated this and had similar rates to the general population with screening for moderate to severe obstructive sleep apnea, with a pretty high sensitivity, as you can see there, and specificity for identifying it. There's been several other studies only looking at nocturnal oximetry as a screener with very good outcomes. So this is definitely something that's building up and something we may see integrated into acute rehab in the future. And then lastly, looking at the optimized SCI trial, what's going to be the future impact of treating this disorder? Luckily for us, there's a randomized control study going on right now, has 44 spinal cord injury patients with moderate to severe sleep disorder breathing. They're looking at the difference between early CPAP use within 8 weeks after injury versus delayed CPAP use at 6 months. Primary outcomes are going to be neurological and functional recovery, so something exciting within the PM&R world. All right, so I know we covered a lot. I wanted to answer some of those questions that I proposed to you in the beginning of our presentation, starting with how common are sleep disorders in patients with spinal cord injury. As we discussed, they're highly prevalent amongst all subtypes. Sleep disorder breathing by far and away is the most common, with rates 3 to 4 times greater than the general population. What is sleep disorder breathing? Starting with the definition, it's an umbrella term. So it includes obstructive, central, mixed apneas, as well as hypoventilation syndromes. Talking about why it happens, there's changes in central respiratory control. We see changes in upper airway collapsibility that we talked about, as well as respiratory muscle weakness. And lastly, these changes in autonomic outflow, which obviously can impact these patients. And then who's at risk? So we see increased risk with higher level injuries and complete injuries. And the key feature, if you remember the red star, is that many of these patients lack daytime sleepiness. So we have to have a low threshold to screen. To what extent do sleep disorders affect functional recovery in spinal cord injury? When we're talking about sleep disorder breathing, it's many clinical outcomes, cardiovascular and cerebral vascular that we talked about. However, the impact on function and neurological recovery is currently uncertain. When it comes to insomnia, this directly impacts comorbidities, especially our depression and anxiety, which have an impact on quality of life. And then there's been some smaller studies looking at insomnia associated with spinal cord independent measures and some functional outcomes. And wrapping up the first part of our presentation, which treatment interventions matter most? For our sleep disorder breathing, it's going to be CPAP, BiPAP, or ASV, depending on the predominant features. For insomnia, cognitive behavioral therapy is first line. However, we need a lot more research specific to spinal cord injury. And then using our normal pharmacologic pathways and addressing psychiatric conditions as well. Looking toward the future, how can future approaches better address sleep-wake disorders in our spinal cord injury patients? We talked about some new novel methods, including mandibular advancement, especially in patients that can't tolerate CPAP. We talked about objective screening protocols, such as the two-step model, and using nocturnal oximetry to really screen our patients. And then lastly, some of the upcoming research that's ongoing, looking at functional and neurologic recovery when addressing these patients with the optimized SCI trial. These are my resources, and I'll open it up for any questions at this time. Thanks for listening in.
So that was really great. I think you did a really comprehensive overview. What do you think our role is on inpatient rehab? When should we screen, either clinically, or should we be getting a sleep study on all the patients while they're inpatient? We do have the ability to get sleep studies and sleep consults for our inpatients now.
Yeah, I think that's a great question. I think based on the most recent literature over the past 5 years, the pretest probability for a patient having a sleep disorder breathing is pretty high. If they're a true spinal cord injury, the probability is pretty high. Even in the paraplegic patients, they saw that the rates were about 77%. So not as high as tetraplegia, but pretty high. So authors, at least some of the recent literature I read, are suggesting that we should be screening these patients because the long-term clinical outcomes are certainly there. Reduced stroke risk, reduced risk of nocturnal hypertension. So we know clinically it makes sense to identify and treat these patients for their long-term health. I think the interesting component is going to be the functional data as that comes out. Are we going to make a difference if we treat it early on their functional outcomes and neurologic recovery? That's to be determined, but I think just from the basis of their long-term health, it makes sense to screen these patients, given that there's a high prevalence, even mild cases, they could benefit from treatment and getting our sleep colleagues on board.
Yeah, I mean, there's certainly issues with long-term cardiovascular health and cognitive health in these patients that we still don't fully understand their metabolic syndrome. So this certainly ties into it. Yeah, I think maybe it'd be interesting to get some sort of protocol, both inpatient and outpatient, or a pathway in terms of screening these patients for sleep disordered breathing. Maybe something we could work on.
Definitely, I agree.
Anyone else have questions?
I was curious, and I'm just going to ask you to hypothesize. I don't necessarily know if there's an answer on that red star, right? Is there something about the injury of it in and of itself that makes it difficult for patients to be aware of that lack of sleep?
Yeah, it's a great question. A lot of the researchers are also uncertain about why this is happening. Why do we see a greater rate of spinal cord injury patients not having the daytime sleepiness component that is very typical of obstructive sleep apnea or apneas in general? Like I said, there's theorized that it may be related to just the autonomic changes that are more common in spinal cord injury, as well as some just pure differences in the actual sleep cycle itself in spinal cord injury. But it's all theory at this point, so I don't think anyone's really certain.
If there's no other questions, again, last time, I'd like to thank Dr. Verlado for his excellent presentation. As usual, all of the videos of these presentations are available on YouTube. It's been a little bit of a break since we've done these, so I applaud you for getting back into it. So thank you, and that will wrap it up.
Thanks, everyone, for joining.